having Dr. Maciejewski and myself to talk about exciting PNH, and we're going to talk about new therapies. So, as you all may already know, PNH is an acquired somatic mutation in the PIGA gene on the X chromosome, which leads to defective synthesis of GPI anchor proteins, leading to development of PNH and its clinical manifestations associated with intravascular hemolysis. PIGA can be found in a small number of hematopoietic stem cells in normal individuals also. So it's not necessarily that it has to have clinical manifestations. It has been found in normal individuals. It's characterized by hemolysis due to the action of the terminal complement on abnormal RBCs lacking CD55 and 59. And PNH RBCs are more readily susceptible to complement-mediated hemolysis because they lack the CD55 and 59 GPI anchor proteins. Note, PNH granulocytes and platelets are sensitive to the complement pathway also, and has a very close relationship also, which we'll talk about later on, about the complement activation and in relationship to the coagulation system, which can increase the risk for thrombosis. As we know, a blood stem cell can give rise to all cells of the blood. And we know that the PIGA mutation arises in the blood stem cell, which can also affect all the stem cell, all the cell lines that are derived from the original mother or stem cell. And we know that especially RBCs and PNH are more susceptible because of, to the complement system compared to the white blood cells and platelets and other cell lines that are derived from the stem cells. So the pathophysiology, as described, is we know that a stem cell, the PIGA mutation is acquired in the stem cell, and that clone expands, which leads to the clinical manifestations of PNH, of hemolytic intravascular hemolysis. And here's a busy slide to just go over the pathophysiology of PNH. So we know that the PIGA mutation is acquired in the stem cells, and that clone actually expands to leading to clinical manifestations of PNH. So we know that the complement system is a very intricate system that helps with proteins that regulate our immune system, and basically helping us fight infections, help us with moderating stress, and fighting off bacterial infections. But in PNH, the complement system is activated, complement is activated, which leads to clinical manifestations of thrombosis, pulmonary hypertension, and complications associated with that, which we'll talk about in more detail. The combination of the alternate and classical pathways and the lectin pathway, we know that the current therapies for PNH are targeting C5, which we know is eculizumab and ravulizumab. Dr. Maciejewski will go into further detail about the treatments that are in the pipeline for PNH that are working on different parts of the complement system and better help managing patients with PNH. And so we can better improve the quality of life of patients, improve their blood counts, reduce their risk of thrombosis and other clinical complications associated with PNH. So most clinical presentation of PNH, as we talked about, there's varying degrees of anemia. So you see there's symptoms associated with hemolytic anemia. It's like, so when we as physicians look at it, we're looking at low hemoglobin associated with elevated LDH, elevated reticulocyte count, and decreased haptoglobulin. And a lot of the clinical symptoms that patients present with could vary from anywhere from abdominal pain, headaches, fevers, esophageal spasm, erectile dysfunction, renal insufficiency, thrombosis, and pulmonary hypertension. A lot of these symptoms may be associated with because of the fact that when there's active hemolysis, there's decreased nitric oxide due to sequestration of the free hemoglobin into intravascular system, leading to the symptoms of smooth muscle dystonia, so allowing having esophageal dysmotility. The renal insufficiency is related to the iron deposition and also related to the microthrombi associated with the intravascular hemolysis. And we know pulmonary hypertension is a similar pathway also of the microthrombi associated also with the intravascular hemolysis. Exacerbation of the hemolysis can be also related to infection, surgeries, or transfusion. So this is where we call breakthrough hemolysis of patients that are on PNH treatment. And we use, in these circumstances, we may have to use steroids to help patients mitigate those symptoms, even though despite maximum therapy. Note, in many cases of PNH, it's important that can be, aplastic anemia can occur with patients with PNH. It can be diagnosed before or after the identification of PNH. The PNH clones are presented in approximately 20% or higher patients with aplastic anemia and can be presented in patients with MDS also. So it's very important when you're evaluating patients with aplastic anemia or MDS to evaluate for a PNH clone. If there's unexplained cytopenias that are not explained by or not explained by other reasons. So bone marrow biopsy would be helpful. And also it's important to assess when there's a hemolysis of unclear etiology. There is, with patients with aplastic anemia and MDS, there's an increased incidence of acute leukemia because of the 10% in 10 to 50% in 10 years. That risk is there with patients with these conditions. Most severe complication of PNH is thrombotic complications, which we have venous thrombosis, which can occur in the extremities, but Chiari syndrome and thrombosis of the hepatic vein or splenic vessels, intra-abdominal vessels, cerebral strokes, superior sagittal thrombosis. Thrombotic tendencies are also enhanced in pregnancy. So labs that we frequently look at during patients that are on PNH therapies or newly diagnosed with PNH are LDH, D-dimer, low haptoglobulin, and either elevated or decreased reticulocytosis, depending on the context of where PNH is occurring. Whether it can occur in the context of aplastic anemia or in the context of MDS, and that's something to look at when first evaluation and during the treatment therapy for PNH. There's no specific morphological abnormalities on the RBCs and PNH on the smear when you were looking at peripheral smears, but bone marrow biopsy will reveal erythroid hyperplasia, which is something important to keep in mind, because the thing is you can have erythroid hyperplasia and there could be some evidence of aplastic anemia in that context also. That's something to evaluate with the expert pathology in your institution. Late occurring iron deficiency can occur in patients with PNH due to the chronic urinary loss from the intravascular hemolysis. And there's commonly you could see some degree of leukopenia and thrombocytopenia in patients with PNH. So most of the time, it's PNH is, because it's a rare condition, it's not commonly diagnosed by physicians unless there's a high clinical suspicion. So if there's unexplained cytopenia, thrombosis of unclear, of abnormal location with the unclear etiology, unprovoked thrombosis, this is where you may want to consider, if you have cytopenias, you have an unprovoked clot, this is where you may want to consider a PNH diagnosis. So PNH, the original test where we used to assess for PNH was the HAM test, but now technology has evolved where we use high sensitivity flow cytometry to detect small abnormal clones of monocytes and granulocytes because they have shorter half-lives to assess the PNH clone. So we use FLAIR assays that bind with high affinities of GPI anchor proteins of most cell lineages, and their help is mostly in monocytes and granulocytes to assess that. So when you get these flow cytometry testing back, you'll see a breakdown of the test. They'll give you type 1 PNH, which is no deficiency of the GPI anchor proteins, but type 2, which there's a partial deficiency of CD55 and 59, type 3, which is complete deficiency of CD55 and 59. So just know one thing that's important to keep in mind. You can still have a type 2 PNH clone and still have increased risk of thrombosis there too. You don't have to have complete deficiency of CD55 and 59 to have increased risk of thrombosis. And the size of the clone, regardless of the size of the clone, any evidence of even low level of hemolysis can increase the risk of thrombosis. And so the thing is, that's something to monitor as if you are diagnosed with PNH, your clinician will monitor periodically to make sure they're watching for expansion of your PNH clone, or it could actually decrease in this clone size or stay stable. And from here, I'm going to let Dr. Maciejewski take over and talk about all the exciting clinical therapeutics. As we've talked about with rabeluzumab and eculizumab, he's going to tell you more details about that and all the new up-and-coming treatments coming up which are exciting for PNH patients.
Thank you, Bumikha. This was wonderful. Conceptually, we have to understand that getting rid of PNH stem cells would not be sufficient to cure the disease. PNH is, unlike leukemia, associated with a decrease of our own healthy stem cells. So the conceptual approach to the curing of the disease includes not only getting rid of PNH, this defective stem cell clone that causes hemolysis and all the other symptoms. But if we would just get rid of it, which would be likely possible with some approaches, we would be left without normal stem cells, which are highly diminished in patients with PNH. Thus, the cure will come from replacing normal stem cells or re-expanding normal stem cells and contracting the stem cells that are defective, that carry the PGA mutation Bumikha spoke about. Now, the only approach to it that is currently available is, of course, bone marrow transplantation. And I want to limit what I'm going to say now to patients, to adult patients with PNH. There is a host of issues in children that Dr. Hanna and other specialists who specialize in pediatric hematology could explain, including the fact that the results of bone marrow transplantation in children are much better than in adults, and that children having entire life in front of them, of course, the consideration for a curative approach might be different as in adults. Conversely, the emotional process of decision-making in terms of transplant or not transplant is very different. So please take my few words about transplantation with a grain of salt, because I'm talking about adult patients. And in general, once around 12 years ago, the complement inhibitors have been introduced, the view towards transplantation has changed because we learned how to better manage the disease in patients. So paired studies, case control studies have been conducted, whereas patients who didn't have a donor were either treated with complement inhibitors or transplanted, and the severity of the disease was matched. We call it case control study. For every patient who got transplant, there was a patient who was studied who has similar disease who couldn't get transplant for various reasons, including he didn't want to. And when the results were tallied, at the end of the day, what came out is that in terms of survival, there was a benefit towards not doing the transplant. Now, this has been, however, consumed or understood in the context of the disease that these patients had. In some circumstances, there is no question that the transplant is completely indicated, and these exceptions to the typical PNH of a particular severity, these exceptions include that patients, in addition to PNH, has severe aplastic anemia that cannot be fixed or uncontrolled, and that the patient, despite of anticoagulation and C5 inhibitors, still continues to have blood clots. These two conditions constitute an indication to bone marrow transplantation beyond what I told you about the results of the case control study. So I think the best to express it is that the decision for transplantation, bone marrow transplant in patients with PNH, has to be very individualized, and of course, giving the emotion behind it and goals in life and characters, as this is something that has to be discussed in terms of the life goals, treatment goals. Some patients are very conservative and rather do less than more. Some patients want the fix, would like to take a chance. This, of course, drives the decision-making process in different directions. But as in general, having C5 inhibitors currently and many other inhibitors in line, we are very conservative in applying bone marrow transplantation to a garden variety. I'm sorry for this mundane word, everybody's disease is special, to a typical PNH. Now, maybe Bumikha, you can forward the slide. You were driving it. Yeah, so if we don't do the transplant, the only curative option currently available, what do we do? Well, patients who need transfusion need to be supported with transfusions, and in typical hemolytic PNH, one of the sneaky symptoms that can be present is iron deficiency anemia, which make, of course, the blood production less efficient. Now, once receiving many transfusion, patient develops iron overload, but in general, a patient with PNH who does not have transfusion is usually losing iron due to hemolysis and urinary losses. Now, if patients had thrombotic events, they need to be anticoagulated. And there is slight difference how we would manage in a patient without complement inhibitors who have chronic hemolysis. So a little bit every day, the red cells are being lysed versus due to some events such as unrelated sickness, have so-called hemolytic crisis. In either way, steroids seem to be effective in acute episode or prevention of acute episode if applying early on. And I don't want to mandate here a chronic use of corticosteroids in such as prednisone in PNH, but clearly there is a role in selected patients or in those who develop symptoms of hemolysis and catch it early on. We used to apply so-called Medrol pack, ask patient to hydrate, and of course, acute hemolysis can be sometimes stopped by simply giving a transfusion, whereas the PNH cells are diluted by normal cells. Now, one of the ways of dealing with anemia that is a consequence of hemolysis is, of course, to improve our own production of hemoglobin. So this is, however, not always possible because in many patients with typical PNH, the erythroid or the red cell production is already maximally cranked up. So by measuring reticulocytes, which are these baby red cells, they indicate to us whether patient's own production of red cells is sufficient. But if this reticulocyte count is not very high, it means that we can improve compensatory own red cell production. And this would happen via various measures. One could use RNS or Procrit, particularly if the level of RNS and erythropoietins are low. We can optimize iron level if patients are iron deficient. Now, some clues as to the nature of the improper compensation might be given by low platelet count, in which case the low platelet count in PNH indicates that there is also coexistent bone marrow failure, and this can be approached using immunosuppression such as cyclosporin or Prograf tacrolimus, also known. So these are the two drugs that we could use. In systematic studies of ATG applied to patients with PNH, there was no major benefit. So unless the patient has coexisting aplastic anemia, ATG is not the treatment for hemolytic PNH. I think we can go to the next slide. Well, I want you to take a deep breath, and we are, of course, not expecting anybody to know it. And I have to confess that complement cascade, which is a system of proteins that circulates in our blood, is very complicated. And if I would ask 100 doctors to tell us about it, I would say the 98 would not know the complement cascade. But once you deal with PNH, you learn the key factors, which are relatively easy to remember. Complement pathway consists of classical and alternative pathway. The classical pathway does not play such a big role in PNH versus alternative pathway, which is the way to activate complement by various stimuli, such as tissue injury, infections, and acidification of serum, etc. This alternative pathway is a major activation pathway in complement in patients with PNH, also in normal individuals, but in those, the defect does not exist. So there is measures to prevent hyperactivation under normal circumstances. And this is the very nature of the disease, whereby PGA mutation causes lack of these proteins that prevents the activation. I'm not going to go back to the mechanism of the disease, but I think it's important to understand 3 steps. The final step in hemolysis, destruction of red cells and potentially some platelets and other PNH type cells, is the activation of C5 and production of so-called membrane attack complex. You see it indicated as yellow. Now, the other step, key step, is the C3 step, but as you know, I'm going backwards from the very end of the cascade, is the so-called C3 amplification loop. The C3 is a key factor because, as you see, the classical and alternative pathway merge here from 2 directions. So there are 2 ways to activate, but C3 and C5 are always the part of final activation pathway. And that's why C3 and C5 would be key factors that if we block, we will stop the complement activation. Now, in recent years, we realize that there are ways to improve, to stop activation of alternative pathway only. And to that end, factor D and factor B are 2 proteins that are essential for activation of alternative pathway. The other factor, called factor H, we are talking here all about proteins, is one that prevents activation. So in the past, there were approaches to produce drugs based on factor H. So factor H would be given and prevent the activation. Now, factor D and factor B are triggers. So we want to block the factor B and factor D. We want to block C3 and we want to block C5 because these are the key steps in hemolytic cascade. Now, as you see with the arrows, I indicated the most popular, if you wish, approaches taken by the industry and academia to generate drugs. And I gave you here an example of these drugs that are very well underway or already available to patients in terms of the new drugs and development of new therapeutics for PNH. There are many more of companies that attempt production of various modification of these blockers on different stages, but some of them are in less advanced stages of development. And I wanted to focus on a couple of them because they constitute examples that are well advanced and are sort of within a reach in terms of being available to the patients. So I hope that there are not companies that will blame me that I didn't mention their drug, but you know, there is such a variety of therapeutics coming to testing that I wanted to focus on a couple of them. And if somebody has question about others, I would be more than happy to answer. So I think we can move and start with the C5 inhibitor. The C5 inhibitor blocks the C5 level. So at the very, very last stage of the complement cascade, and is currently available. There are 2 of them available. One is called eculizumab, and second is called ravulizumab, also known as Soliris and Ultomiris. It binds C5 and prevents assembly of a protein complex, which is called membrane attack complex, that ultimately leads to destruction of red cells. Now, these two drugs are currently on the market, and as you know, eculizumab was replaced by ravulizumab, which make the administration less often. So eculizumab is every 2 weeks, and ravulizumab is every 5 weeks. Now, they are, of course, downsides. The drugs are very well tolerated because they are monoclonal antibody based on human protein. However, blocking of complement by itself increases the risk of meningitis, of a certain bacterial infection, and therefore patients have to be vaccinated. Now, I don't know whether we have a next slide, Bumikha. Yeah, so here you see that the C5, and I sort of collapsed the complement cascade to only the alternative activation pathway. So the C5 blockade is what works at this level with Soliris and Ultimaris, both available. Now, the caveat to it is that blocking C5 sometimes is insufficient. And that's why many patients, if not majority, do not have complete response. So you block C5, yet there is additional hemolysis, if you wish, leakage of the system. And this usually occurs at the C3 level, which I'm going to come to it. Now, needless to say that what is coming really to fruition are two very far advanced developments, a drug which is crovalimab and a drug which is called pozelimab. Both of them are similar in effect on C5, and therefore, if somebody does not respond to C5, I don't think this would be a rational approach. But both of them have certain advantages, in particularly that they are very long-lasting and can be self-administered. Interestingly, pozelimab is made by this company that produce a drug for COVID that President Trump received. This is a very advanced monoclonal antibody that patients are planned to be self-injecting, so it gives a certain degree of freedom. Again, if somebody does not have a response to C5 or the response is not optimal, these two drugs, in my opinion, are less likely to fix the problem. And next. Now, as you can see in the cascade, what's above it, so if we block it earlier, is the C3 molecule. We call it in the complement world C3 amplification loop. It turns out the blockade of C3 amplification loop is very effective in blocking what's below, but also it takes care of the leakage. And thus, the blockade of C3 might improve responses to C5 inhibitors. But now that the trials were advanced, we know that the C3 blockade might be effective by itself. And thus the patient with C3 inhibitors might not need C5 inhibitors, which because they take care of the further pathway. If you wish, it's blocked at the earlier stage. Now, I have to say that there are other antibodies for C3 in development, but the development is further away, so I'm not going to talk about it. The currently developed drug that is very close to FDA approval is called persepacoplam. I'm sorry, the names became crazy and more complicated. There is some system to how these drugs are being named, nota bene. This is not, nobody comes up with a crazy name like this. But in any event, the bottom line is that the benefit would be blocking of intravascular and extravascular hemolysis. Extravascular hemolysis is responsible for treatment failure of C5 inhibitors. Now, this drug has been tested and is very effective. In some head-to-head comparison, looks even better than C5 inhibitors. Now, the caveat to it is that it was compared to C5 inhibitors given to patients who did not respond very well to C5. So head-to-head comparison in new patients might have looked different, but needless to say that the drug is at least as effective, if not better, by preventing also the extravascular hemolysis. Now, the way it's going to be administered, if FDA approved any soon, is that it's going to be self-administered. And it sounds great, but unfortunately it is not an EpiPen type of approach or insulin injection. There is a small gadget that one has to strap on the belly and insert 2 needles in the fat or in the leg, and a machine, a pump, pumps the drug slowly over 30 minutes or so into the patient. Now, it sounds burdensome, but I know patients who got the drug, who were non-responders to C5 inhibitors, and they managed as well. But it sounds a little bit, because this procedure has to be done not once daily, but every other day. So, and of course, you cannot forget about it. You have to be sort of prepared. But at the end of the day, people tell me that taking a little bit of time and doing it for yourself once every 2 days is not such a big deal. You can decide. Now, so I would then move to the next development, which is also exciting. And this deals with the fact that the burden of self-injecting, taking care of, going to the clinic, infusing it, or waiting for the home health nurse to arrive to infuse it in a patient, worrying that the drug will be delivered in your front desk and somebody snaps the box with, for those who get the eculizumab at home, might be elevated by the fact that there are 2 good developments. And I'm going to talk now about the factor D. And at least 2 companies, they are more, I list here. One is called BioCryst, and then Achillion, that was recently purchased by Alexion. These are pills which essentially block complement at the very early stage. So they block, if you wish, take care of the C3 activation and C5 activation. They block it at a very early stage. So before the hemolysis just start to act up. And the Achillion drug, the danicopan, has been tested and as a 3 times a day pill, and now currently redeveloped as a 2 times a day pill. And it seems to be working very well. However, since the purchase of the Achillion to danicopan, the first development of this drug will be only in patients who are refractory or who don't have optimal response to complement inhibitors that are available, to the C5, Ultomiris, and Soliris. Now, possibly later on, it could stand as a lone agent, and many of us are pretty certain that it would be sufficient to use only factor D and factor B blockade without needing the infusions. But this is a first plan is to use it in conjunction or in addition to the available C5 inhibitor in a patient who does not have super response. And it looks like it's going to be very effective. Now, the final development is factor B inhibitor, which is called LPN-023. It might have already a name, but as you know, company develops these compounds, these chemicals tested, and it takes a long time before they decide it's so promising that we give it the name. Now, this drug is very promising. It might as well have a name, but the company called it LPN-023. And this drug has been given to patients who did not respond to C5 inhibitors. And the effects, at least in a European study of some 20 so patients, were excellent. And the plan is that the drug will be developed for both new patients and those patients who have C5. In fact, the responses in some of these patients who had eculizumab were so good that doctor decided just to stop eculizumab all along, and the drug stand by itself as a pill, as twice-a-day pill. It's relatively well tolerated, and the clinical trial is coming to some of the institutions. We hope to have it pretty soon. Through COVID, everything was delayed. We were hoping to be able to offer this clinical trial to patients now. Now, unfortunately, unlike Achillion, the Alexion, the factor D inhibitor, the currently planned clinical trial will be phase 2 trial in which every patient will get the drug in addition. Once he is on C5, he will get it. And the trials for factor B inhibitors are slightly more complicated because there will be a control arm, so patients will be randomized, and for a period of time, the chances are that one patient might be not receiving the actual drug. Now, but eventually it's going to be all worthwhile the effort. It looks like in preliminary results in China, and it looks good in Europe. So, and it's going to be a Northern American trial as well here. In fact, 2 trials, 2 parts. One as an addition to non-responding patients with C5 inhibitors, and the second as an upfront regimen, whereas patient does not have to infuse anything, will just take the pill. In any event, these are very promising new drugs in the toolbox of hematologists that will be available soon. There is a big effort financially spent by this company, so I'm pretty confident once they are committed to this, they are going to follow through. And pretty soon, in addition to the 2 otherwise very good drugs, we will have other options, and including possibly life-changing pills. So this is what I have to say about the treatment. And I want to ask Bumikha whether she has something to add.
So in conclusion, as Dr. Maciejewski went over, there will be choices for therapy for patients with PNH in the future, and very soon, I think. I think Dr. Maciejewski and I have had some experience taking care of patients on combination therapies with C5 and factor D inhibitors, and patients have done well, especially when they've not had adequate responses to C5 single agent therapies alone. So I think therapies for PNH are going to become more individualized, depending on the clinical context of these patients, or where patients may be on combination therapies or single agent therapies, depending on the biology of their disease. Patients will have preferences. I think there's going to be patients who want to be on IV formulations of therapy or sub-Q or oral therapies. So I think this is something to look forward to as more comes out from these trials. And we're excited to be, at the cutting edge of it and being able to take care of these patients. There will be agents that are going to have better pharmacokinetics, meaning these drugs that may have longer activity. So the frequency of administration of these drugs may be longer and longer. So I think that's going to be something, it would actually improve patients' quality of lives and better adapt it to patients' lifestyles and decrease the clinical visits. And while the cure is not in sight, because we know the only curative intent for PNH is bone marrow transplant, I do think that new drugs will convert this disease into a more manageable condition, in improvement in symptoms and also improvement in quality of life. Curative treatments are being conceptualized, but there's more hope now than there has been since the initial approval of eculizumab back in 2007, and I think we're at the era of new therapies and exciting drug development and new options for patients to come. So thank you for having both of us, and we'll take questions.
Thank you, Dr. Patel. Thank you, Dr. Maciejewski. We've got just a few minutes here for questions. Our first question is, Dr. Patel mentioned reticulocytes can be high or low in the presence of MDS and aplastic anemia. What is associated with high reticulocytes, MDS or aplastic anemia?
So, and Dr. Maciejewski can answer too. So when I was discussing that, so when PNH occurs in the context, so we would have to look at the PNH in the context of aplastic anemia. Sometimes one of the diseases dominates the picture, over the other one. So in the context of if aplastic anemia is the more dominating feature of the underlying bone marrow morphology and the blood counts, the reticulocyte count might be lower. If the PNH clone is smaller and not actually active hemolysis, a clinically relevant hemolysis, you may see a lower reticulocyte count in the setting where compared to active clinically relevant PNH, you'll see a higher reticulocyte count. And in MDS, mostly you see a low reticulocyte count, but the PNH clone is usually small. So that's why you see a lower reticulocyte count in the MDS context. And usually hemolysis is lower level, but it's something that we can see in patients with MDS as an overlap bone marrow failure condition.
Sorry, I had myself on mute. Our next question is there a course of treatment for medication-caused hemolysis?
Well, it depends on the nature of hemolysis. Most devastating, of course, would be a complication that in the past was common and now never exists is infusion of incompatible blood when the groups were mismatched by medical error or by necessity or rush. This causes massive hemolysis, and the drugs in this setting might be effective. In terms of the hemolysis caused by chemical agents, of course, the complement inhibition might be helpful, might not be helpful. Now, there is a condition called autoimmune hemolytic anemia, and there are several forms of them. And in fact, cold agglutinin disease might be susceptible to being treated with complement inhibitor versus other types of hemolytic anemia are not mediated by complement but by antibodies, and thereby the effect of complement inhibition might not be of therapeutic value.
And just to add on to what Dr. Maciejewski said, usually the removal of the offending agent will help improve the hemolysis, but it may take time. And I think that's where, depending on the clinical the context of the drug being used, you would have to do the appropriate antibody testing and consider using the appropriate therapies for that in that setting. So agree with Dr. Maciejewski on that.
Thank you. Are there any oral drugs in the pipeline to control PNH symptoms?
Well, as mentioned, the factor B and factor D inhibitors, there are others too, but these two are two major drugs that are very close to the market.
Thank you. This patient is getting ready to have a bone marrow biopsy, and they'd like to know what are all the procedures and tests that should be taken to get the most information from a biopsy?
Well, bone marrow biopsy are usually performed in patients at the very beginning of the diagnostic cascade. Once PNH is established, unless they are particular reason, we don't biopsy patients with PNH that often because the diagnosis is established and there is very little surprise. Now, at the beginning, it's nice to have a baseline bone marrow that will tell us, or there is a reason, for example, occurrence of immature cells or severe cytopenia that involves also white cells to assess how much aplastic anemia is in the bone marrow. But the typical PNH patient, hemolytic patient, does not need frequent bone marrow biopsies. Now, having said that, the current standard is to obtain cytogenetics. It means to look at the chromosomes, look at the morphology, look at the cellularity of the bone marrow, which in typical cases would be elevated. And finally, now the new test that can be added is sequencing to look for associated other mutation, including PGA. So this test is applied routinely in some institution and not routinely in other institution, whereas it has to be extra ordered. And it's useful to have it, but again, you know, one has to see it in the context of the last 100 years of medicine, where we manage PNH without the sequencing. But now that it's available, it's a clearly useful tool to distinguish several types of PNH and to look at co-associated diseases.
Well, thank you so much, Dr. Patel and Dr. Maciejewski, for sharing your time and expertise with all of us today. If you would like to watch this session again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question today, please feel free to submit it to us in 3 ways. Send an email to help@aamds.org, call our help line at 800-747-2820, extension 2, or submit your question on our Facebook page. This session is going to end, and we will restart our next session within 10 minutes. You will need to rejoin the conference using the same Zoom link or phone number provided in your conference email and registration. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family, as we have done for the past 36 years. This concludes our session.
Thank you.
Thank
Good
you.
luck
Thank
and
you.
have a nice weekend.